Once Mr. Choi downloaded the same slide, you're gonna to show us the screen. You're gonna to share the screen. I continue.
Yes. Yes, you can continue.
Yeah, thank you. As I said, threatened abortion. Threatened abortion is when there is a new vaginal bleeding with or without lower abdominal pain, but the cervix is closed and all products of conception are in situ. Okay. Now we go on a clinical presentation of threatened abortion. We have minimal vaginal bleeding, cervix os is closed, uterus size correct to depth, minimum abdominal pain. Investigations. Ultrasound to confirm gestation age and fetal viability. And then we do full blood count because of bleeding. Another one we do even analysis and therapy and RBG. Okay. Management. Excess work is discouraged because of them. Avoid coitus. Admit the patient and manage appropriately if the fetus is dead. We move to inevitable abortion. Inevitable abortion. This is where process of abortion has progressed to a state where continuation of pregnancy is impossible. Sign and symptom: we have moderate or severe vaginal bleeding, which may be accompanied with clots, severe lower abdominal pain, significant draining of liquor if membranes have ruptured or membranes may be intact. The cervix is dilated with evidence of immediate expulsion of product of conception. Fundal height may correspond with the gestation age. Presence of uterine contraction. Yes, we go to investigation. Investigation, we do full blood count, we do group 1 X match. Treatment, these people we treat, we do primary survey, and then we can also give IV, we can give Lingas or normal saline, 2 liters. We can also do augmentation. The process if membranes are ruptured by administration of oxytocin 20 international units in 500 mils normal saline or Lingas at 40 to 60 drops per minute. Manage as incomplete abortion if after expulsion some product of conception remain in the uterus. Manage as complete abortion if all products of conception are expelled. Go to incomplete abortion. This is a type of abortion where some of the products of conception have been retained in the uterus cavity and there is a persistence lower abdominal pain, continuing the vaginal bleeding and the open cervix. Sign and symptom: we have cramping, lower abdominal pain, slight to profuse vaginal bleeding, accompanied with clot and product of conception. Fundus smaller than that, the cervix is dilated and product of conception may be felt in the cervix. Yes, sir.
You are too fast.
Okay. Thank you. Noted. Investigation. We do full blood count. We also do group and X match because of bleeding. And treatment, we have supportive and pharmacological on this one. So supportive, we start with the primary survey as usual, and then we go to give blood give blood transfusion if indicated, whereby like if you see in your full blood count you say HB is low, we have to give blood and perform MVA at the health center if gestation age is below 12 weeks. If above 12 weeks gestation and patient have retained the placenta, perform a manual evacuation. This is why I said I included this 2 points below here. This is because like sometimes these people they can present at your local facility whereby like you can't do MVA because of lack of equipment. Okay, so we move on pharmacological treatment. So on pharmacological treatment, you can give oxytocin 10 international units IM, or we give Risprosto 600 milligram per orostat after evacuation. Then after evacuation, give amoxicillin 500 milligrams TDS for 5 days per oral, and metronidazole 400 milligrams TDS for 5 days per oral as well. And then we accompanied by paracetamol 1 gram TDS for 5 days. Refer the patient to hospital level with an escort of a nurse if bleeding continues. Sometimes it happens whereby like you can at your facility you can handle this, you can do MVA and other thing, but you find that the bleeding is profusing. So at the end of the day, you find that instead of you losing a patient, so it's better you transfer the patient to another level, higher level compared to your facility, if your facility can't afford. Thank you. And then after that, educate patient, counsel, and provide appropriate contraception. Go to complete abortion. Complete abortion, this is a type of abortion where products of conception are completely expelled. We have silent symptom, minimal or vaginal bleeding, uterus smaller than date, and often well contracted. Cervix may or may not be closed. Investigation, we do ultrasound, we also do for blood count. Yes, we go for treatment. We give amoxicillin 500 milligram TDS for 5 days, and then also give metronidazole 400 milligram TDS for 5 days. Also give iron folate, 1 tablet BD for 3 months, and and after every 4 weeks, yes, reassess after 4 weeks. The reason why we say reassess after 4 weeks, and the reason why we don't give patients these iron and folate for 3 months at once, because these people they don't want to come back to reassess if they feel good. They feel to say they are feeling good, but in actual sense, these people they like to come back to hospital after this because of complications. So it's very important to give them for a month, for every month, so that every month they will be what coming. In order for them to come and get the same medicine, they have to come as well to do what to be checked. Okay, and then uh, we give fluids. We give normal saline or numerous 3 liters or more in the first hour. Give blood transfusion if indicated. Insert an Arduino utero catheter. Give IV eftraxone 1 gram plus metronidazole 500 IV start. If a patient to hospital with an escort of a nurse as I indicated. I think I explained on this point. Okay. Move to the next level. We go to missed abortion. So missed abortion is a type of abortion where fetus dies in utero but it is not expelled out. We have sign and symptom, which is history of amenorrhea, subsidence of pregnant symptoms, uterine size smaller than death, mild vaginal bleeding. We go for investigation. We can do abdominal pelvic ultrasound, throat profile, FBC, and then we go for treatment. We induce abortion with mistrostol as follows. First trimester, we give 800 milligrams per vagina, or we give 600 milligrams sublingual every 3 hours for a maximum of 2 doses can be repeated after 24 hours. In a case of 13, if the pregnancy was 13 weeks to 17 weeks, we give 200 milligrams per vagina QID. And if the pregnancy was 18 weeks to 26 weeks, we give 100 milligrams per vagina QID. Evacuate if less than 12 weeks. After evacuation, give amoxicillin 500 milligrams TDS for 5 days, plus metronidazole 400 milligrams TDS for 5 days. Also, paracetamol 1 gram, 1 gram TDS for 5 days as well. We go to septic abortion. Yes, septic abortion. This type of abortion were associated with clinical evidence of uterus and its content. Sign and symptom of septic abortion includes abdominal pain following history of abortion, fever may be present, foul smelling vaginal discharge, which may be mixed with blood, may be in shock or and jaundiced. Tender uterus, there may be rebound tenderness. Cervix is usually open. Investigation, we do FBC and DC. Also do endocervical and blood culture. Also do group and self and X match. We do ultrasound and bedside protein time. We go for treatment. We go diet for pharmacological because of time. Pharmacological, we give cephrazone 1 gram IVBD for at least 5 days, plus metronidazole IV 5 milligram TDS for at least 5 days. And educate patient and counsel provide appropriate contraception. Yes. We go to complication of abortions. The following are some of the complications of abortions include generalized peritonitis, DIC, hemorrhage, the toxic shock, mostly due to E. coli, structures. This marks the end of my presentation. Thank you guys for your attention and for your time. You can please educate me and ask where you are not clear.